throughout the whole process of pregnancy as well as during the birth, the woman is going through a lot of psychological as well as physiological changes. Chapter 12 will look into what happens during the period immediately after giving birth, which is called the postpartum period. In some cases, this period is also referred as the fourth trimester of pregnancy. Now, if the woman had almost 9 months, 40 weeks in an ideal pregnancy to adapt to the developing fetus and to adjust to the reality of becoming a mother, now during this time, this realization of the new role as a mother and the recovery of the body after the pregnancy and childbirth happens. The postpartum period, it's also called puerperium, and it's being looked as the length of the next 6 weeks immediately after birth. We'll divide this period for the easiness of understanding into 3 different categories. We'll have the immediate postpartum period, which will cover the first 24 hours. We'll have what is called the early postpartum period, or the first week, and the late postpartum period, which refers to the weeks 2 to 6. All of those elements that are related to the maternal adaptation to the postpartum period will be discussed in chapter 12. Please take a moment to stop this presentation in order to review the learning objectives for it. So as said before, during those 40 weeks of pregnancy, a lot of changes happen to the pregnant woman. And there is actually no body system or organ that was not affected by the pregnancy. During the postpartum period, the woman will will go through the process that allows the body to recover. Let's look first into the most affected system of the body, which is the reproductive system. The involution is the process by which both the uterus, cervix, and the vagina will return to the non-pregnant sizes and functions. And we'll describe each of those now. Let's look now into what happens with the uterus. Immediately after and we are looking now at the immediate postpartum period. Immediately after the placenta is delivered, the uterus will contract and will contract inward. And by doing that, this process allows for the sealing of all the open blood vessels that were present and open now at the former site of insertion of placenta. Whenever the uterus is not contracting effectively, the result will be a hemorrhage, a postpartum hemorrhage. In addition to that, there is a clotting cascade that will be initiated in order to help control the bleeding. Gradually, there will be a slough off of the decidua, while the new endometrial tissue will form, and the area where the placenta was inserted will heal without leaving any type of scar tissue. And this is important because when looking from the inside of the uterus after the pregnancy, a year later or years even later, we're not going to see a scar as we see in the healing of other tissues. So by contracting itself, the uterus is allowing and will produce the uterine involution. And there is a predictable rate. And if you look at the slide, you can see in the image, what is the predictable rate of uterine involution. And we do that, we can predict it by measuring and monitor as well. We can predict and monitor by measuring the fundal height. So immediately after the delivery, the uterus, when we examine the abdomen of the mother, the uterus should be felt as contracted and firm, with the fundus located midline and at about the level of the umbilicus. So immediately after the birth, at the end of the birth and the delivery of the placenta, the uterus will be contracted, will feel firm, not floppy, and at the level of the umbilicus. The day after the delivery, The fundus will be found 1 finger breadth, about 1 centimeter below the umbilicus. So the normal process of involution from that point further will be one that will allow the uterus to descend approximately 1 finger breadth per day until it had descended below the level of the pubic bone, where naturally it leaves when it's not pregnant, and will not be, you are not longer able to palpate it. So normally the process of involution will be of 1 centimeter per day. Usually the uterus will descend below the level of the pubic bone somewhere between the day 10 and 14 postpartum. There are some things that we can do in order to promote and encourage the uterine contraction and the involution of the uterus. One thing that helps is the breast stimulation. And the best stimulation of the breast is through the feeding of the baby. By breastfeeding stimulation, the oxytocin is released. Again, oxytocin is a hormone released from the posterior pituitary gland. Oxytocin has a very powerful contracting, stimulating the contractions of the uterus. If you remember, we can provide artificially oxytocin or pitocin through IM or IV routes if needed in order to help the uterus to contract. In addition to that, the normal involution will be faster whenever the mother is having a normal nourishment and is starting to ambulate early. In addition to that, there are some factors that can inhibit or delay the uterine involution. In some cases, a full bladder will prevent the normal uterine contraction and will push the uterus upward, or the uterus will be found displaced away from the midline. So any conditions that overdistend the uterus during pregnancy may lead to an ineffective uterine contractions after delivery. For example, if you have a multi-fetal pregnancy, if the pregnancy is a pregnancy with a polyhydramnios, whenever there is maternal exhaustion or an excessive analgesia, or whenever there is an excessive use of oxytocin during labor and delivery. Other elements that can prevent an effective contraction of the uterus will include retained placental fragments. That's why the placenta should be examined very, very carefully and make sure that all the tiny finger-like projections of the placenta that are called cotyledons, they are present and none was broken and retained at the level of the uterus. Other factors that prevent contraction would be infection or what is called the grand multiparity. And this is a situation of having 5 or more pregnancies in the past of the same patient. Whenever the uterus is not contracting effectively, there will be an accumulation of blood and clots at the level of the uterus. And just by accumulating inside the cavity, that will will be an impediment in a correct and normal contraction of the uterus. What we can observe when we examine a patient like that, we'll see that it's called the bogey uterus, and a hemorrhage will be present. A bogey uterus usually feels very soft and spongy instead of being firm, round, and well contracted. We'll discuss now what is called the after pains. So the uterus will contract and relax in the postpartum period at intervals. So this will lead to what is called the after pain, which in some cases can be quite severe. In premipara, a client that this is the first pregnancy and first delivery, the uterus will normally remain contracted, and the after pains are less severe than those encountered by a multipara client. However, through the breastfeeding, there is a release of oxytocin, and the release of oxytocin will increase the duration and intensity of the after pains for both the primipara and multipara. So you may encounter patients that are complaining of pain during the postpartum period. We'll discuss now another concept, and is the idea of lochia. So the uterus will shed its lining that was supporting and nourished the pregnancy. Lochia represents that uterine discharge that is made out of blood, mucus, tissue, and white blood cells. And it's very common, and it's expected to be observed during the postpartum period. Lochia will go through 3 stages. You will have during the first 3 to 4 days, lochia rubra. It is small or moderate in amount, mainly composed of blood. It can be dark red in color or may have a fleshy odor. The next stage, lochia will become what is called lochia serosa between day 4 and 10. Will decrease to a very small amount, however, will take a brownish or pinkish color. And the third stage of lochia will be lochia alba that will show up after day 10 when the uterine discharge becomes white or pale yellow because the bleeding by now has stopped and the elimination of blood was done. Now the discharge is now mainly composed out of white blood cells. How long do we expect to see lochia? Well, lochia may persist for the entire 6 weeks after delivery. In some cases, may subside by the end of the 2nd or 3rd week. What we shouldn't see ever in lochia will be large blood clots. Some other abnormal findings will include a reversal of the pattern. Let's say we had lochia rubra, we get into lochia serosa, and then goes back to lochia rubra. Also, an abnormal pattern in terms of will fail to decrease in the amount, and it will increase in the amount instead of gradually decreasing. Or we shouldn't see or observe lochia that has a foul smell. What happens now at the level of the ovaries? Well, the ovulation, the ovaries will start to be active again, and ovulation can occur as soon as 3 weeks after delivery. However, menstrual periods usually will begin within 6 to 8 weeks for a woman that is not breastfeeding. In the lactating women, the menses may not resume for as long as sometimes 18 months after giving birth. Lactation may suppress ovulation, however, it's not a sure and dependable form of birth control. So it is very helpful to educate your patients, your clients, and advise in using some other types of birth control to prevent an unplanned pregnancy if they do not want to have another one when they resume sexual activity despite of the breastfeeding. Let's see what happens with the cervix. Well, remember that during the labor, the cervix will dilate and will thin itself. And during this process, there is a certain level of trauma that happens at the level of the cervix. So immediately after the delivery, the cervix will still be partially open and will contain small and soft tears. It may look bruised, and the internal os will close after a few days. Sometimes there may be a need of a few stitches on the cervix, and that will be the decision of your provider. Gradually, the muscle cell will start to regenerate, and all those tears will heal themselves, while the cervix will recover by the end of week 6 in the postpartum period. The external os, so the internal os is the opening inside the uterus, while the external os is the opening towards the vagina. The external os will remain slightly open, and now it's not going to be round like it was in newly porous women, will become a slit line instead of it. Changes at the level of the vagina and perineum. Well, vagina may have immediately after giving birth may have small tears that will may heal without intervention. When we are looking at the walls of the vagina immediately after the delivery, because of the expansion of the muscles of the vagina, the walls look very smooth. And the rugae, all those folds of the vaginal wall will begin to return approximately 3 weeks postpartum. The introitus diameter will gradually become smaller by contractions. However, it will never return to its pre-pregnant size. The muscle tone in the perineum will as well never fully return to the previous state in the pre-gravid state. What can help with that is to perform Kegel exercises that will increase the tone and will allow to enhance the sexual enjoyment in the future. Keep in mind that breastfeeding will suppress ovulation, and as a result of that, the estrogen levels may be very low in a breastfeeding, lactating woman. And as a result of that, the woman may experience vaginal dryness and what is called dyspareunia, which is the painful intercourse. At the level of the perineum, the labia and the perineum itself may show up as having edema immediately after delivery. They may look bruised, especially if that was a difficult delivery. If an episiotomy was performed or any kind of perineal tears are present, the repair will be done by suturing with absorbable stitches. The edges of the episiotomy or the repair should be approximated as good as possible. The labia usually change in their structure, and they tend to be flaccid immediately after childbirth. There are changes at the level of the breast as well, and at this level, we'll discuss at the level of the breast, we'll immediately in the immediate postpartum period, we'll observe the colostrum, which is an antibody-rich breast secretions, which is not the breast milk. It's a precursor to it, and will be normally produced by the breast in the last week of the pregnancy and continues to be produced in the first few postpartum days. There is an increased level of prolactin, and that happens when estrogen and progesterone levels will fall immediately after the delivery of the placenta. The actual suckling on the breast will increase the delivery and the production of prolactin level. The prolactin will stimulate the milk production by the breast, and the actual breast milk will start to show up in the 3rd day postpartum. We'll discuss a little bit about the cardiovascular system. And I will start by saying that there is an extra fluid volume that is present at the end of the pregnancy. This fluid loss will start to be eliminated through the skin, the urinary tract, and through blood loss. In a normal vaginal delivery, there is a certain level of blood loss that can be between 300 and 500 milliliters of blood during the delivery itself. Whenever there is a cesarean delivery, a C-section, the blood loss can increase and may be seen between 500 and 1 liter. As the blood volume returns to normal, some of the hemo concentration will occur, and that will increase, will cause an increase in the hematocrit. In the immediate postpartum period, there is an increase in the plasma fibrinogen levels, and this happens along with an increase in the levels of the coagulation factors that are an adaptation because there is an increased chance for bleeding. So the body is trying to protect the mother from this happening. So this protects against any type of hemorrhage, and however, there is a downfall for it because there is an increased risk of developing as well blood clots in the deep veins of the legs, and this is called deep vein thrombosis or DVT. Another risk factor, in addition to an increase in the coagulation factors, is the fact that there is a certain degree of dehydration in a postpartum period. There is a certain degree of immobility and the trauma itself that the woman's body is going through. There will be an increase in the white blood cell count immediately after birth. That can be seen up to 20,000 per milliliter. and sometimes even 30,000 per milliliter. Their main role is to prevent and protect the woman from infection, while during the pregnancy, there are so many routes for infection to penetrate the woman's body. Immediately postpartum, you can see that the temperature of the woman will increase slightly, and they may experience what is called the shaking postpartum chills. And this is a result of all the physiologic changes due in the drastic change in the levels of the hormones. Those chills are not harmful, and this is should be an alert for you only if the fever will be greater than 100.4 Fahrenheit, or if you observe other signs of infection. Those chills usually resolve in a few minutes and can be treated easily having a pre-warm blanket that you are placing over your patient. Let's look at the vital signs. And the temperature can be slightly elevated during the first 24 hours, and this is due to the intense exertion and dehydration during the labor. However, it is abnormal to have a temperature that is higher than 100.4 Fahrenheit. This may indicate infection. The blood pressure should remain as previous whatever your client had before as a baseline. An elevated blood pressure could be a sign of developing preeclampsia and should be reporting. However, a falling in the blood pressure, particularly in the presence of a rising pulse, is suggestive of hemorrhage. So monitoring the blood pressure and the pulse is essential in the immediate postpartum period. What happened with the, let's look what happened with the musculoskeletal system. So probably the most pronounced changes will be evident at the level of the abdominal muscles. However, other muscles may be weak because of the exertion of the labor as well. The abdomen should be soft and sagging in the immediate postpartum period. Usually your clients will wear loose or maternity clothing for the first few weeks after the delivery. The abdomen will gradually regain its tone with exercise. In some women, the abdomen may remain a little bit slack. In this situation, and if another pregnancy occurs, the woman will have more problems with backache. There is a condition that is called diastasis recti abdominis, or rectus abdominis diastasis, which represents a separation of the abdominal muscles during the pregnancy that leaves part of the abdominal wall without muscular support. It's not per se a hernia, and it's not a rupture in the fascia. It's just a separation of those two muscles in the midline where the linea alba is. Exercise can improve the muscle tone and may correct the situation. The gastrointestinal system. Immediately after delivery, most of your clients will be very hungry. There is a lot of energy that was expended during the labor process that will deplete most of the glucose stores in the body. There is a restriction of fluids and loss of fluids during the labor in the urine or via diaphoresis by sweating that will lead to an increased feeling of thirst. Immediately postpartum, constipation may be a problem. And the intra-abdominal pressure decreases rapidly after childbirth, while the peristaltis is still diminished. This may make more difficult for the feces to travel through the gastrointestinal tract. In addition to that, your patients may be afraid to go to the bathroom in the early postpartum period because of some may have hemorrhoids already developed, or because there is a perineal pain and they are afraid of the effort or the pain that can be expected with that. So suppressing the urge to defecate may complicate the problem of constipation, and iron supplements will increase the consistency of the feces. By the end of the first postpartum week, the bowel functions should be usually returning to normal seen before. Urinary system. Well, urinary system will start to handle an increased load in the early postpartum period, while the body will eliminate all the excess plasma volume. If your patient has healthy kidneys, they will easily adjust to the increased demands, and the urinary output will be increased. There will be a transient glycosuria, proteinuria, and ketonuria normal immediately postpartum. During the process of labor and delivery, trauma can occur to the lower urinary system, especially to the level of the bladder and the urethra. In addition to that, certain medication or anesthesia given during labor can lead to a temporary loss of bladder sensation. And as a result of that, your patient may experience urinary retention. In some situations, your client may void small amounts. However, she will not completely empty the bladder, or she may not be able to void at all. This usually happens when the urethra was traumatized. In this immediate postpartum period, urinary system is more susceptible to infection. Hydronephrosis, which is the dilation of the renal pelvises, is a normal change that is the result of hormonal influences, increased renal blood flow, and the pressure put by the uterus on the ureters. The condition usually returns to normal 4 weeks after the delivery. Question number 1. A 26-year-old G1, P1 has delivered a healthy baby girl. You are providing client teaching. One of the subjects you know to cover is the restarting of ovulation and menstrual cycles. One point you need to stress is, and the options are, A, lactating women may not restart their menses for more than 24 months. B, menses always begins before ovulation. C, you can get pregnant as long as you are breastfeeding. Or D, you can conceive even if your periods have not restarted. Correct answer is D. You can conceive even if your periods have not started yet. And the rationale for that is the fact that the return of ovulation and menstrual bleeding do not always occur together. And this is an element that will need to be explained clearly to the client, that she may be able to conceive, that she will be able to conceive even if she is not having her menses resumed immediately. What will be the other aspects of the maternal adaptation to postpartum from a psychological point of view? Well, the role change is probably the most significant psychological adaptation that the woman needs to make. And this process will occur with each new addition to the family. However, it is more pronounced when it happens with the first newborn. Each child definitely is unique and will present with his or her own temperament and needs. Based on that, each child will need to be integrated into the existing family structure in a different way. It is definitely a challenge while the whole family must adapt to the addition of a new member. So let's look into the process of becoming a mother. So your patient, your client, begins the process of becoming a mother during pregnancy while she anticipates the birth of the baby. The woman will fantasize about and prepare for the newborn's arrival, and after the birth, the client, the woman, must actually take on the role of mother to the baby. There are two critical elements in becoming a mother, and those are the development of love and attachment to the child and the engagement with the child. The engagement will include all the activities of caregiving as the child grows and changes. This transition is continuously evolving and is a process that will change throughout the woman's life in order to adapt to the child's needs. There are four developmental stages through which the woman will adapt to her new role as a mother. One, and the first one, will be beginning attachment and preparation for the infant during pregnancy. The second will be an increasing attachment and learning to care for the infant, while the physical restoration during the early postpartum period. And the third one will be moving toward a new normal in the first several months, with the fourth one being achieving a maternal identity around 4 months. All those stages are not really clear cut in between them, and they overlap, and they can be influenced by social and environmental variables, and their length can be different from one client to the other, as well as between one child and the next one. In the early postpartum period, most of the new mothers will show a type of dependent behavior. She may seem to have difficulties making decisions and will need assistance with self-care. She will have this kind of tendency of being focused inwardly and concerned about her own physical needs, such as food, rest, and elimination, more than the baby needs. She relieves the delivery experience. She actually has a great need to talk about it in details. And this process is important for her in order to integrate the experience into her concept of self. Your clients may still stay in the dependent phase for several hours and sometimes for days. Keep in mind that you need to listen with an attitude of acceptance and no feelings that your client will express are wrong. Try to help and interpret the events of her birth experience for the woman. Most women move quickly from this dependent stage to an increasing the independence, both in self and the newborn care. This is the result of the woman being able to rest and recover somewhat from the stress of the delivery and the exhaustion, the efforts during the delivery. At this point, your client will become more receptive to infant care instructions. So this is a good point to start doing performing your education. For a first-time mother, it's a particular and special need to reassurance that she is capable of providing care, that she will be able to care for the newborn. The attachment represents that part of development of an enduring bond. It develops between the parent and the infant. Keep in mind that this attachment process is not one that happens automatically. Attachment develops in time, and it happens along with interaction. And it's related to the way that the parent interacts with the infant and the response to the infant. In the early postpartum period, each client, each woman may have a wide range of emotions and responses to the newborn. Not all of us humans can respond to gains and losses in similar way. So if you observe your client exhibiting signs of disbelief or shock as initial reactions, that just can be very natural. So ambivalence is a very normal response in the first stages. The new parents may communicate uncertainty over their readiness to take on the parent role, and they may feel skittish in taking over in the first stages. The initial component of healthy attachment is the process called bonding. This is a way that a new mother and father will become acquainted with their newborn. And the process begins with a very predictable pattern of parental behavior. It will start by an initial inspection of the newborn, by touching it. The new mother will explore the newborn's extremity, maybe counting fingers and toes. She will touch the whole newborn and begin to explore larger body areas. It's essential to encourage your client to spend as much time holding the newborn in what is called en face position, in which mother and baby are interacting with each other face to face. The new mother is encouraged to talk to the baby using high-pitched notes, smiling and laughing to the newborn, and all those elements will contribute into the initial developing the initial and healthy bonding with the newborn. Another stage of healthy bonding behavior will be by the moment when the parents, especially the mother, are naming the newborn and they are calling the newborn by the name. Making eye contact, talking are indicators of a healthy attachment. It's essential for you as a nurse to be able to differentiate between a parent that is nervous because it's a new parent and anxious because of a new role that they need to take on, and a parent that is rejecting the parenting role. And some warning signs of poor attachment will be turning away from the newborn, refusing or neglecting to provide care, and disengagement from the newborn. Keep in mind that along with the mother bonding with the newborn, the rest of the family needs to start the bonding process as well. The father will benefit from early contact with the newborn immediately after delivery. Most of the time, the father will describe strong emotion as pride or joy and positive emotions when he will first hold the newborn. Along with the father, siblings will also bond with a newborn and will accept the newborn in the family. We'll discuss now a little bit about what is called the postpartum blues, and approximately between 40 and 80% of the postpartum women will experience some form of postpartum blues, or sometimes it's called the baby blues, which can be described as a temporary condition that usually begins about the third day after delivery, and it's not lasting more than 2 to 3 days and should be resolved by 2 weeks postpartum. During this time, the client may exhibit symptoms of sadness. She may be irritable. She may show anxiety, difficulty sleeping and eating, and may have a decreased ability to concentrate. And all this is related to the huge hormonal storm that happens. There is a decrease in estrogen and progesterone immediately and abruptly postpartum period, and this is considered to be part of the picture. However, the exact cause is unknown. There are, however, some factors that have been identified that may contribute to the development of baby blues. It is important for the woman and her family to understand that this is a normal reaction. However, if this mood disturbance or so-called depression lasts for more than several days, or if the symptoms may become severe, it is essential to instruct your clients to contact her healthcare provider or seek some medical attentions immediately. Question number 2. When providing care to a postpartum client, it is important to assess the new mother's psychological adaptation to the infant. You know that there are 2 critical elements to becoming a mother. What is one of these elements? And the options are A, learning to care for the infant, B, engagement with the child, C, redevelopment of love and attachment to significant other, or D, moving toward a new normal. Correct answer is B, engagement with the child. And the rationale for this answer is the 2 critical elements of becoming a mother are 1, development of love, and 2, development of attachment to the child and engagement with the child. Engagement includes all the activities of caregiving as the child grows and changes. We'll look now into the nurse's role in postpartum care, and during the postpartum exam, the nurse needs to focus on 11 areas. So we'll start by looking into the essential body system and elements when examining your patient. Those will include, and I will start by breasts. Breast needs to be inspected, and the nipples will be observed. We are looking for signs of engorgement, redness, or cracks. The breast needs to be palpated gently to see if they are soft, they are engorged with milk, and we need to note any areas that is painful. Uterus. We'll examine the uterus, and the woman will need to be positioned lying supine. The fundus will be palpated. The position of the uterus will be noted, as well as the tone and the size. Again, the uterus needs to be firm, not boggy, located in the midline, and at the appropriate height in relation to the umbilicus, depending on the time after delivery, hours or days after delivery. While we examine the uterus, we pay attention to the lochia. We are determining the amount and the character of the lochia, and we journalize it as scant, small, moderate, or heavy. If it's rubra or serosa, if it has any kind of foul smell, and make sure that you are checking under the buttocks of your patients to make sure that blood is not pooling under. In addition to that, make sure that you're asking your patient how many times she has changed her sanitary napkins or pads since your last check of the fundus. In addition to that, ask her how saturated the pads were. The bladder and the bowel. Well, your patient should be encouraged to void as soon as possible. Most probably at the beginning, your patient will be able to void adequate amounts that will be more than 100 milliliter per each voiding. Avoiding a pattern that is frequent and in very small amounts, especially when it's associated with some suprapubic distension, may be indicative of a urinary retention. We'll inspect the abdomen visually and we'll auscultate for bowel sounds. They should be present in all 4 quadrants, and we'll always ask the patients regarding if they had a bowel movement since delivery or not. Examination of the perineum. To do that, we'll need to assist the woman into a same position. If you do not remember what the same position is, please, this is a good time to review what the same position is. We'll lift the top buttock, and with a good light source, we'll inspect the perineum for redness, edema, or any type of ecchymosis. If your patient had an episiotomy or a tear, we'll need to check the sutures and make sure that the edges are well approximated and that there is no hematoma forming in that area. As well, note if there are any hemorrhoids, and as a general evaluation, the perineum should be intact with only minimal swelling and no hematomas. We'll examine the lower extremities. The extremities will be examined for edema, equality of pulses, and capillary refill. We are examining and trying to diagnose as soon as possible a potential DVT. There should be no pain at the level of the calves when the client is walking. We also can examine and feel along the calf area and observe for any kind of warmth or redness. The calf should be equal in size and warmth bilaterally, no redness, no painful areas. The pulse should be equal on both sides. Evaluation of pain now. We need to determine what is the level of pain that the client is experiencing. We also will try and investigate the source. Is that an after pain? Is that a pain at the level of the episiotomy? Is it pain during urination or pain in the calves, for example? In addition to that, we try to determine the characteristics, the quality, the timing, and what reliefs in terms of comfort measures. Don't forget about your lab studies, which will be monitoring for hemoglobin and hematocrit. We need to know what is the level of hemoglobin and hematocrit before delivery. Most of the healthcare providers will probably order a postpartum hematocrit and hemoglobin level in the morning after the delivery. And any significant drop may have been investigated in depth to see if there is no sign of hemorrhage. We need to note the blood type and the Rh, and if the woman is an Rh negative patient, she will need lab studies to determine if she is in need for Rh-OD immunoglobulin injections before discharge. We'll also have to determine the woman's rubella status, and if she is non-immune, she will need an immediate rubella immunization before discharge. We'll examine and look into the maternal emotional status as well as the maternal newborn bonding. We'll observe any time that the newborn is in the room present with the mother. We'll observe and note any type of interaction of the mother and the newborn. We'll observe the interactions during the infant's feeding, and we'll document the quantity and the quality of the social support needed by the mother. We'll make notes regarding her mood and affect, and we'll try to observe for any signs of poor attachment. In terms of nursing interventions, again, we are going back to all the assessment that we did before. We'll be preventing and detecting any type of hemorrhage, treating pain, preventing infection, preventing falls. And this is essential because the first time the woman gets up, she is at a high risk for fainting and falling because all the postural hypotension. Especially when the woman is going to get out of the bed for the first time after delivery, we will need to assist her. And we'll do that by instructing her to dangle her legs at the side of the bed for 5 minutes. If she's not feeling dizzy, we'll assist her to the bathroom and will remain with the client until she returns to bed. We'll need to return her to bed immediately if she feels dizzy at any time. We'll help to sit her down and have her head forward for a few minutes if she cannot lay back in the bed. If the patient begins to black out, we'll need to gently support her to the floor until she comes to. We'll need to detect and treat any type of urinary retention. In other words, we'll promote urinary elimination. We'll encourage to empty the bladder as soon as possible. We'll help her to the restroom to void. In some cases, because of regional anesthesia, this is not a possibility. In this instance, we'll need to assist the client to sit up on a bedpan. We'll need to make sure that she receives enough privacy. If she's having any difficulty avoiding, we can run water in the sink or use a peri bottle to run warm water over the perineum to help releasing the sphincter. In terms of promoting bowel elimination, all the normal measures that help prevent constipation will be helpful. The general measures will be helpful in the postpartum period. Adequate fluid intake, early ambulation will stimulate the normal bowel peristaltis. We can add fruits, vegetables, and fiber in the client's diet to prevent development of constipation. In some cases, a bulk forming agent such as psyllium, which is metamucil, may be very helpful. Preventing any kind of damage from thrombus formation will be, the prevention of thrombus formation will be realized by assisting the client with early ambulation as soon as possible. Will decrease the chance, this will decrease the chance of thrombus formation and will promote the venous return. In addition to that, we'll encourage plenty of fluids to prevent dehydration. We'll try to promote a restful sleep. We'll monitor the woman's sleep and wake cycles, and we'll continue to encourage her to have any kind of pre-sleep routines that she normally had at home. We'll promote a relaxing and low-stress environment before sleep by dimming the lights, monitoring the noise and the traffic near the woman's room, especially during her sleep time. We'll medicate for the pain if needed, especially at bedtime, to promote a good rest. We'll discuss now the nurse's role in the postpartum care of a patient that had the delivery through a C-section. The patient that is going through a C-section has a significantly increased risk for death than those that will deliver vaginally. Causes for an increased risk for death are related to complication of anesthesia, postpartum infections, hemorrhage, and thromboembolism. So a patient that had experienced a C-section will require a very close monitoring. In this case, will include auscultating lung sounds every 4 hours in the first 24 hours and at least every 8 hours there immediately after in the second day. Definitely the lungs need to be clear without any kind of adventitious sounds and should not be diminished in any lobe. We'll monitor our patients for any signs of respiratory depression as a result of use of narcotics such as morphine that most of the time is used in conjunction with the spinal or epidural anesthesia. We monitor for the IV rate in terms of flow and correct solution, and we'll check the IV site at least every 2 hours for redness, swelling, and pain. In the case of a C-section patient, the IV should stay in place for the first 24 hours after the delivery at least. Any types and any kind of pain will be investigated in terms of defining the source and the type of discomfort that the woman is perceiving. In terms of sources of pain or discomfort, they can be very similar to those that are perceived by a woman that delivered vaginally. In addition to that, the additional source of pain for a C-section patient is the abdominal incision. Any buildup of intestinal gas may be perceived as shoulder pain. Our other sources of which are the shoulder pain is a referred pain are additional sources of pain. Common side effect of narcotic administration during vaginal anesthesia is the itching or the pruritus of the skin. The abdominal incision is a site for possible complications, and we are looking for signs of hemorrhage or infection. We are monitoring for the drainage on the dressing side in the first 24 hours, and we check the incision at least once every 8 hours after removing the dressing. When we describe the incision, this needs to be well approximated with sutures or staples. A small amount of redness is normal. Any drainage from the incisional site that is an increase in the amount of redness or edema, all those are abnormal findings and need to be reported. We will monitor the bowel sounds at least every 4 hours, and we'll check for abdominal distension and pain associated with gas formation. Especially after C-section deliveries, the woman may experience difficulty passing the gas because of a decreased peristaltic activity. We'll observe, in addition to that, the indwelling catheter for urinary output, and in most cases, the catheter will stay in place for the first 24 hours after a C-section. The output should be at least 30 milliliters per hour with a clear yellow or light straw color. Any type of cloudy urine is associated with, should be suspected for infection. After removing the urinary catheter, we need to observe our client for the first few voids to make certain that she is voiding adequately and is not exhibiting any signs of urinary retention. We are going to look now into the last stage of this lecture that refers to the postpartum period, and this will be how do we prepare our clients for discharge? Well, just like any other client that we have, the discharge planning starts upon admission and will continue throughout the admission period until the client leaves the facility. So most of the interventions that are related to discharge will focus on informing and educating the woman on how to care for herself and the newborn when she goes home. We'll need to make sure that we include in the education elements regarding breast care, how she should do on her own fundal massage, how to monitor for the lochia, describing each of the stages that the lochia will go through, the time in the postpartum period when this should appear, and how to monitor for the quality and the quantity. How to perform perineal care, pain management, how to prevent constipation, and prevent fatigue. In addition, we'll provide information regarding those so-called danger signs that the client needs to report immediately, as fever, pain, dysuria, foul-smelling lochia, increased quantity of lochia, any type of calf pain, or feeling of persisting sadness. Question number 3. Tell whether the following statement is true or false. RHO-GAM, RHO-D immunoglobulin is given to an Rh-negative mother who delivers an Rh-positive infant to prevent the formation of antibodies they may attack future fetuses. The statement is true. If the woman is Rh-negative and the baby is Rh-positive, the woman will need an injection of RHO-GAM to prevent the development of antibodies to Rh-positive blood. The woman must receive the RHO-GAM within 72 hours of delivery to be most effective. This will protect future development of future pregnancies.